Okay, the next representative condition we'll talk about is acute post-streptococcal glomerular nephritis. And again, you could see this as APSGN, glomerular nephritis, acute glomerular nephritis. Again, just take a minute to kind of wrap your head around and get the name straight. This is a non-infectious autoimmune disorder. With this one, we have generalized edema caused by decreased glomerular filtration, which begins with periorbital edema, and it progresses to the lower extremities, then to ascites. And don't forget, ascites is fluid accumulated in the abdomen. We'll see a decrease in our urinary output. I'll talk a little bit more about urine here in a second. So basically what's going on with this disease process, we have immune complexes are deposited in the glomerular basement membrane. Because of these immune complexes being deposited, the glomeruli become edematous. This occludes the capillary lumen, which results in decreased plasma filtration, which leads to increased water and sodium reabsorption, so holding on to that, which will expand our plasma and interstitial fluid volumes, which leads to circulatory congestion. So that's kind of a little bit about the etiology of acute glomerular nephritis. So just kind of take a minute to wrap your head around that. And acute glomerular nephritis starts on page 1344 in your text. Now let's talk a little bit about the assessment. So for the assessment of urine, it'll be thick, reddish brown. If you remember when I talked about strep throat in our respiratory, this was one of the things that we need to make sure we're on the lookout with our patients that have a strep infection. But it looks like you've basically poured a can of cola into the toilet when they pee. So we say it's cola or tea colored, so a reddish brown, and it is in decreased amounts, okay? So they do have a couple of different phases with acute post-streptococcal glomerular nephritis. We have an acute edematous phase, and that's around 4 to 10 days. Our labs during this phase, you'll see severe hematuria, mild protein in the urea, and we will take, we'll have increased specific gravity because they are dehydrated. And they'll have decreased blood flow to the kidneys because of that circulatory congestion. In their blood, we'll see increased serum protein levels, increased potassium levels, and they'll have an elevated anti-streptolysin O titer, or an ASO. That's your strep titer. Remember, this is after a strep infection typically, so that strep titer will be elevated. A normal strep titer is 170 to 330 TODs per microliter. On assessment, we'll also see hypertension due to that increase in that extracellular fluid. It'll cause the blood pressure to go up. And then don't forget, when we have a high blood pressure, we're worried about headache, we're worried about encephalopathy, we're worried about seizures. So with the encephalopathy and the seizures, so that fluid going to the brain, we'll see some neurological changes. So you'd look for that on assessment as well. Mild to moderate periorbital edema, increased weight due to that fluid retention. During this acute edematous phase, some general complaints on assessment will be abdominal pain, malaise, anorexia, vomiting, pallor, irritability, lethargic, and fever. After we have that acute edematous phase, we'll have a diuresis phase start. And it's basically just what it says. We'll have copious diuresis. So they're going to start getting rid of all of this excess fluid. As they start to get rid of all this fluid, we'll see everything else. Our clinical signs and symptoms will improve. Their weight will decrease because we're getting rid of that extra fluid. We'll see a decrease in the gross hematuria during this diuresis phase, but microscopically with acute post-streptococcal glomerular nephritis, we could see hematuria microscopically for weeks to months after this disease process. Sorry, forgot to flip the page there. The issues that we will be worried about with this disease process are fluid volume excess related to decreased urine output, and we're holding on to that excess water and sodium, okay? Remember, it expands the plasma. We've got this excess in the interstitial fluid, and it's causing circulatory congestion. Altered nutrition less than body requirements related to anorexia and vomiting, pain related to fluid retention, high risk for infection related to diminished body defenses, and again, knowledge deficit related to the disease process, the treatment, and the follow-up care. All right, for our fluid balance and our complication, we want to make sure that we are checking the blood pressure at least every 4 hours. Remember, we talked about that hypertension. We want to check daily weights. With each urine, you want strict INO. You want to check the specific gravity, and you want to check for blood with every void. Again, we can do that at the bedside using a dipstick, as long as your facility allows that practice. With the edema, just like the other one, you want to note the extent, location, and progression. If there's any fluid restrictions, we would want to adhere to this. Their activity initially will be bed rest due to hypertension. And don't forget, we're worried about encephalopathy. We're worried about seizures. And again, with that fluid going to the brain, we're worried about increased intracranial pressure. So make sure you're doing frequent neuro checks. Make sure those are ordered. If there's any lingering strep, we would administer antibiotics. We would administer antihypertensives. We would administer diuretics. And if we're seeing any heart failure because of this increased fluid, we might need to give some digoxin. And we would also do, in addition to those daily weights, we want to do daily abdominal girth if there's any ascites present. So remember, we talked about that fluid collecting in the abdomen. We want to monitor that. Adequate nutrition, regular diet in uncomplicated cases, but no additional salt. Possible potassium restriction if we see oliguria, and there would be protein restriction with azotemia. Again, azotemia is an increased BUN and creat. Don't forget, protein is hard on poor functioning kidneys, so we got to see what those kidney functions are doing. We still want to stimulate their appetite, smaller portions, favorite foods where appropriate, meals with family, and cultural preferences. Provide reasonable comfort, make sure parents are visiting, provide positional changes, good skin care, and provide appropriate diversion. Prevent further infection, a lot of the things that we've already said, good hand washing technique, limit contact with people who are infectious, administer antibiotics if ordered. And again, we're usually only giving antibiotics if they have those positive strep cultures. Make sure we're keeping them warm and dry, stress good hygiene. And again, make sure you're noting possible sites of infection. How do their lungs sound? How does their skin look? Any skin breakdown secondary to that edema? We have those same issues as we had with nephrotic syndrome. And then again, if we're not catching those systems that are breaking down, it could become a systemic infection. All right, your health teaching for acute post-streptococcal glomerular nephritis and discharge. We would want to teach the patient and or the parents how to check their urine at home. Again, dipstick for protein in blood. Remember, we said that hematuria may persist for weeks to months. They might not see it in the urine, but when they do the dipstick, it could show hematuria. If they're starting to see blood in their urine, that's a good indicator that they're doing too much and they need to slow down their activity. That leads us to activity restrictions. No strenuous activity until hematuria is completely resolved. Like I said, if there's no hematuria, if we can't see blood in their urine and then we see blood in their urine, they're doing too much. We got to slow them down. Make sure the patient and the family understands that. We need to make sure we're doing patient and family teaching about low sodium, low potassium diet, possibly a low protein diet. We'll need to see what's going on with the kidneys. Well, obviously they'll have some follow-up care with their doctor. They could have home nursing coming out, lots and lots of follow-up care with the doc. Parents usually want to know, is this going to happen again? And again, subsequent reoccurrences are rare because of the specific immunity is conferred with that, with them having strep. So they typically don't get this again. Your evaluation and outcome criteria is normal fluid balance is maintained or restored, adequate nutrition is maintained, comfort level is achieved and maintained, no secondary infections, child and the family verbalize their understanding of the disease, its treatment, and its prognosis. 95% of these cases, rapid improvement to complete recovery. 5 to 15%, we could see a chronic glomerular nephritis. In 1% of the cases, we have irreversible damage. Our next one, our last representative condition for the GU system is Wilm's tumor, a nephroblastoma. And Wilm's tumor was taken out of our GU chapter, and it's in the cancer chapter. You'll find that information on page 1321. But typically on assessment, the most common sign is abdominal mass. Typically, it's firm and non-tender. Again, with any mass, if we find any mass, we don't palpate it. We note the mass, and then we make sure that we are getting the doc in to take a look at it. But typically, the parents will find this mass when they're changing the diaper. It's felt as a mass over the anterior kidney area. And again, when they have a mass in that area, their waistband could start to tighten. If they're out of diapers, they could notice it that way too. And Wilm's tumor is a malignant renal and intra-abdominal tumor of childhood. It is three times more common in African American children. The peak diagnosis is around age 3, and we see this most frequently in males. We will do an intravenous pyelogram or an IVP. This visualizes abnormalities of the urinary system. That IVP will confirm the diagnosis. Metastasis occurs most frequently to the lungs. They could complain of chest pain, cough, dyspnea. Those are some indicators that we have metastasis to the lungs. We have 2 areas that we're concerned about: altered urinary elimination related to space occupying lesion in the kidney, and then we have knowledge deficit related to diagnosis, treatment, and prognosis. First thing we need to do is promote normal urinary function. And how we do that is we get the child to surgery quickly. Sometimes they'll do pre-op chemo and radiation to decrease the size of the tumor, but they like to go in within 24 to 48 hours of the diagnosis and do a nephrectomy and take out the adrenal glands as well. So inform the family that surgery is scheduled, and again, as soon as possible after we confirm that diagnosis. Preoperatively, the biggest thing is just to keep that mass intact. Don't palpate the mass. That tumor is highly friable, and it can increase metastasis if that tumor would become disrupted. Our post-operative care would, our nursing care with any patient going to surgery, what you're going to monitor there. Your vitals, your surgical site, INO, obviously, how's the kidneys functioning. Post-operative care for this child could also include long-term radiation therapy and chemotherapy, and we learned about the effects of chemo and radiation in previous chapters. I kind of put in knowledge deficit in with that. Again, the knowledge deficit is the diagnosis, the treatment, and the prognosis. So again, we're going to hurry up and get this kid to surgery. They may have chemo and radiation prior, and they will have it after. So we would have to do a lot of education regarding chemo and radiation as well. But your evaluation outcome criteria for Wilm's tumor is that the child is able to maintain normal urinary elimination, and then that the parents verbalize the understanding of the follow-up care for this child. Those are your representative conditions for the GU, so make sure you are just focusing your reading on those conditions that we talked about in lecture. If you guys have any questions, make sure you guys are emailing me. Let me know. Thanks.